For this session, we welcome Taylor Laffey, who is a PharmD and the Medical Outcomes and Value Liaison with Indivior. She's here to discuss innovative treatment options for opioid use disorder. Taylor is from Pittsburgh and a graduate of the University of Pittsburgh School of Pharmacy. She has a managed care background, having completed a PGY-1 managed care pharmacy residency at UPMC Medical Health Plan, where she then worked as a clinical pharmacy specialist on the commercial and state-based exchange formulary management team. She also co-coordinated the health plan's pharmacy and therapeutics committee. Taylor is a member of the field medical affairs team at Indivior, and her role as a medical outcomes and value liaison, she covers the states of Ohio and Pennsylvania. Please welcome Taylor Laffey. Thank you.
Okay, can everybody hear me okay with this microphone? Okay, if I need to get louder, just let me know. So thanks so much for having me today. It's great to be here with all of you. As everybody in this room is well aware, the opioid epidemic is still reigning through our country. And while we had seen some positive numbers today about what's going on right here, it's still a nationwide crisis. So I'm really honored to have this time with all of you to really dive into opioid use disorder, to frame it as a chronic disease so that it's not only chronic, but it's also treatable. Before we get started, I'll introduce myself again quickly. I'm Taylor Laffey. I am a pharmacist by training, and I'm on the medical affairs team with Indivior, where I work as a medical outcomes and value liaison. I cover the states of Pennsylvania and Ohio, so that's how I'm fortunate enough to be here with all of you this afternoon. Before I get started, I do have two quick disclaimers. First being that this is the most up-to-date information that we have available. But of course, as new research and data comes to fruition, this information is subject to change. Second being that I'm not able to send these slides out to anybody after this conversation, but I am a resource that will be available to all of you at any point. So this is the roadmap for what our conversation this afternoon is going to look like. And I know it looks like a lot and it's overwhelming, right? Looking at all of these different topics, but I promise that we'll take it in a very slow, digestible form so that we can really hit on all of these key pillars of opioid use disorder. So for starters, we'll dive into opioid use disorders neurobiology, talking about what's actually happening in the patient's brain when an addiction is being formed. We'll then talk about opioid use disorder in closer detail, and then we'll talk about stigma, which is very important to address, especially in a group as large as this one. We'll then talk about the opioid use disorder treatment landscape, knowing that we have different guidelines and associations, recommendations on what gold standard care can look like. But on top of pharmacologic therapies, we're also going to focus on treating these patients as whole patients. There are other factors that we all know play into treatment that go beyond medication. So we'll also talk about behavioral therapies and other psychosocial supports as well. Okay, so diving into our first section, it's very important to level set with everybody first. So what is addiction? The American Society of Addiction Medicine defines addiction as a treatable chronic medical disease. And we know that involves several different circuits of the brain, as well as internal and external factors that really play a role in the progression of this disease. I think that this second bullet point in the purple box is extremely important to recognize that addiction continues despite the negative consequences that somebody faces. And we'll tie this into the brain changes that the patients are experiencing and as to why these behaviors may continue despite being harmful. The National Institutes on Drug Abuse define addiction very similarly to ASAM, where they characterize addiction as a chronic relapsing brain disorder that in many cases is preventable but also treatable. You see again that call out about continued use, impacting a person's ability to exert their self-control, which we know can be seriously impaired. So as I just alluded to, there are different stages of progression that lead to addiction. So we have initiation, then regular use, then that regular use transitions to problematic use, and then to full addiction. The rate at which this progression occurs varies from person to person, and this is very individualized. We know that there are three main groupings of factors that impact this progression. First being external factors, things like stress, home or family environment, social influence, the availability of the substances, and even things like childhood adversities and traumas. There are also internal factors like heritability, sex, current age or age when somebody first uses, history of other substance use disorders, as well as having other psychiatric comorbidities. So we'll pause here and think about how these two types of factors can impact certain parts of this progression. So for instance, we know that extrinsic factors tend to be most important for that initial exposure and pattern of use, whereas those internal factors that we talked about tend to be more important in the transition from regular use to problematic use. The third grouping of risk factor is the drug itself. We know that drugs act differently in the body, and this causes different opportunities for patients to experience addiction. So things like how the drug works in the body, how it's taken, how much is taken, all also contribute to this progression. So I keep talking about how addiction is a brain disease. So let's really focus in on the actual parts of the brain that are impacted whenever addiction is formed. There are three main stages of addiction that cycle through and through. First being binge or intoxication, then withdrawal and negative affect, and last being preoccupation and anticipation. So starting with binge, this is really the point in time whenever somebody experiences a positive experience whenever a drug is introduced. This comes from the basal ganglia, which is part of the brain that's involved with the reward pathway. It's also responsible for the pleasurable effects that are felt during this time. And it's also involved with the habit forming behaviors that those with addictions exert. The next stage, withdrawal. This is when someone experiences a negative emotional state without the medication or substance in their system. This stage is driven by the extended amygdala, and this part of the brain is responsible for stress reactivity and stress response. So think, I'm sure many people in this audience have encountered patients who are experiencing symptoms of withdrawal. It kind of looks like fight or flight in some instances, right? Well, those physical symptoms, as well as the mental symptoms, are coming from the extended amygdala primarily. And this is what's driving patients to then that final stage of this cycle, which is preoccupation and anticipation. This is the stage where somebody is seeking out that substance again after a period of time of not having it. This comes from the prefrontal cortex, which is involved with decision making, impulse control, and even weighing consequences. So, with the prefrontal cortex being impaired, our processing centers aren't able to they aren't able to make decisions, and consequences don't resonate as they normally would. So this then ties back to what we saw with those definitions of addiction, the use and habits continuing despite harmful consequences. The part of the brain responsible for understanding consequences is impaired. So next we have the neuroadaptations, and what these really are those physical and structural brain changes that occur in the neurons of the brain. Dopamine is a neurotransmitter that is extremely involved with pleasure in the reward pathway. So remembering that the basal ganglia is also involved here. This also ties back to that first stage being binge and intoxication. As neurons are exposed to drugs, we see that there are actually these physical changes to their structure, which then impairs their ability to function in the same ways that they would in a healthy brain, which then can be contributing to those behavioral changes that we see. So what we see in this image on the right side here, we compare a healthy neuron to a neuron that's had some drug-induced neuroplasticity or brain changes. And what we can really see is that there are these structural, chemical, and functional adaptations that occur. And in some instances, the neurons can even die or neurotoxicity can occur, which again, this plays into those behaviors that we see with our patients with addiction. Okay, so I know that was a lot of the science nerdy background part, but it's important to set the stage to help people understand there are actual physiologic experiences that are coinciding with these behavioral changes that our patients exert. I now want to zoom in onto opioid use disorder, where we'll talk about some statistics, the different waves of the opioid epidemic, and then we'll also focus in on treatments after this section. So in 2021, almost 9 million people reported having misused prescription pain relievers. And in that same year, over 1 million people reported using heroin. I know whenever I hear big numbers like this, I sometimes kind of just let it pass by as just that, as a number, a statistic. It doesn't really resonate. But I want to really take a moment here to humanize these people. These numbers are representative of our community members, our coworkers, our friends, and our family members. We know that opioid misuse, whether it be prescription or illicit, runs the risk of one of the most serious consequences, overdose. We know that overdoses are the leading injury-related cause of death in the United States, and that the pandemic seems to have accelerated the rates of overdose nationally. A big factor in the overdose situations that we are seeing today and that we heard about from some of our previous speakers is the prevalence of the synthetic opioids and how they've really shifted this landscape of the situation that we're trying to battle here. The synthetic opioids are becoming more and more prevalent. And in fact, in 2020, the CDC reported that over 80% of opioid overdose deaths involve synthetic opioids. I know we heard some statistics this morning about fentanyl in this county, and it's quite... Someone might not be muted. It's okay. But in this county, they're similar to this number. So we can see that nationally, this is a major concern. Driving into drug overdose deaths in a little bit more detail, again, I have more numbers for you. It was predicted that over 105,000 people died of a drug overdose from December of 2021 through December of 2022. And during that same time period, all but 23 states showed increasing rates of opioid overdose deaths. And in 6 of these states, those overdose increase rates were over 10%. So Maine, New Hampshire, Oklahoma, Texas, Washington, and Wyoming. Again, we hit on the point that a major driver of these deaths is prevalence and use of the synthetic opioids, whether intended or not. And we talked about the different risk factors that can impact the progression to addiction, with drug characteristics being one of those main 3 circles on that slide. The factors that are specific to synthetic opioids are contributing to their high lethality. So for instance, the synthetic opioids are highly potent. They have a very fast onset. They can cause a greater degree of respiratory depression. They're also less sensitive to reversal by naloxone. So all of these factors in combination together really create quite the dangerous picture for our patients and what they're going up against. We heard from Becky this morning too about how what we're seeing in today's opioid epidemic is not how this started. What we really see are 4 distinct waves that are characterized by some differences in the population. So for instance, when this started in the 1990s, it was largely prescription opioids that were being misused. We then saw a second wave beginning in the 2010s, where we saw this rise in heroin use and illegal heroin overdose deaths. The third wave is marked by 2013, where we started to see fentanyl in the synthetic opioids start to come along. And now we're in what we consider the fourth wave in the 2020s, where we're seeing continued increases in the use of these illicitly manufactured synthetic opioids. So we have things like fentanyl along with all of its potent analogs. And this is changing on a very fast basis. To put things into perspective on how dangerous the synthetic opioids really are, it was reported that from 1999 to 2020, over 560,000 people died from an overdose. So that's a mix of exposure to all of the opioids that we see on this list or on these waves. Thinking to just 2021, there were over 70,000 opioid overdose deaths linked to synthetic opioids alone. So again, to try to humanize this, I'm assuming because we're in Cleveland that we have some Browns fans in the audience. Does pain me to bring up the Browns that I am from Pittsburgh, and we love the Steelers. I know I know Jody was going to have my back on that one, but we can talk about the Browns if we have to. So I looked it up, and the Cleveland Browns Stadium holds about 67,000 people at capacity. So this number of 70,000 is greater than that entire stadium full of people. Think about the last time you were there for a game or a concert and you saw all of those people in the audience and surrounding you. That's the amount of people that were lost in 2021 because of synthetic opioids specifically. Health-related quality of life is very important, and it allows us to consider outcomes of opioid use disorder outside of things like opioid-free status alone. This allows for more patient-centered and honestly more relevant to overall health care. Health-related quality of life isn't often measured by opioid use disorder treatment programs, but note that there are actually validated measures that can be used to measure these outcomes. The key takeaway with this slide is that those with opioid use disorders, we know have lower health-related quality of life, and that there are certain factors that are associated with this poor quality of life, things like being older in age, being a female, and having other mental or physical comorbidities play into this. So because we know that quality of life can vary so greatly for our patients, it's really important that we tune into these different factors whenever trying to personalize care and create individualized treatment plans. So there we go. I talk about how opioid use disorder is a chronic disease. And I want to use this example of cardiovascular disease, another chronic disease that's very common in the population, to really draw out the similarities between these. What you see in these boxes on the sides of the slide are standard for how we treat all chronic diseases. So for instance, we know it's important to stay active and healthy and participate in things like exercise for all chronic disease benefit. Family history plays a significant role. So for both opioid use disorder and heart disease, we know that we need to understand somebody's personal background with these diseases. The importance of reducing stress and having coping is relevant to both of these, as well as having the continuity of care with frequent check-ins with providers, monitoring progress, and looking at treatment progression. It's key to any chronic disease. And lastly, getting access to those treatments and being adherent to them is of utmost importance. So what you can really see is that both opioid use disorder and heart disease have biological as well as behavioral components to them. And often the goal is to stabilize the patient. This can take long periods of time, right? But symptoms can reemerge as a person's life changes, their external factors, as well as their body chemistry changes over time. For chronic diseases, what this often means is that it's time to adjust treatment, and that's it. All we have to do is just take the obstacles as they come and try something new for treatment. There's no reason why opioid use disorder symptoms and heart failure symptoms should signal other than this. So we just set the stage on why opioid use disorder is just like other chronic diseases, but why is it viewed so differently in society? Why are these patients treated differently? And stigma is really the main thing that this comes down to. This is a major factor. So stigma is whenever a group or a person with a specific characteristic is labeled, stereotyped, or devalued, which then leads to discriminatory behavior toward them. We know that stigma can come from many different levels. Individual, like family and friends, can impose stigma, but it can also come from, unfortunately, healthcare providers and even policymakers. A common stigma with opioid use disorder is that it's a choice or a moral failing rather than viewing it as the chronic disease that we know that it is. And all of these different factors can lead to many negative consequences for the patients. We know that their health-related quality of life and how they view themselves is already lower. And then these impositions from society help to create isolation and more barriers to care, which ultimately makes this disease state even more complex to treat. The words that we use when talking about opioid use disorder are very important. For instance, terms like addict or junkie really are stigmatizing and are used to lower our patient's dignity. Using other terms like a person with a substance use disorder or a patient even is much more preferred as it's less stigmatizing. Using words like habit and abuse also contribute to expressing the way that society views this disease and its disapproval of it, whereas use or misuse are much preferred. Whenever we think about heart disease and somebody gets their labs taken, we don't call high cholesterol anything other than hyperlipidemia. We don't have dirty blood pressure readings whenever they're out of range, right? So why are the labs that use disorders any different? We know that a heart attack is an acute exacerbation of the chronic disease, heart disease, and that's not often viewed as a moral failing, whereas an opioid overdose tends to be viewed as that, despite both of these being acute exacerbations of symptoms. Just something to think about. Even the terminology that we're using to describe treatment is evolving. You're probably very familiar with the term medication-assisted treatment, MAT or MAT even. This is now actually being evolved to medications for opioid use disorder, or MOUD, as referring to it as medication-assisted treatment is really insinuating that the medication is only secondary to whatever the primary treatment is. That medication should only have a temporary or supplemental role in somebody's journey, whereas using language like medications for opioid use disorder provides effective language to help call out the tangible benefits that medications can have in patients' lives. We know that medication is best used in combination with behavioral therapies and other psychosocial supports, but we also do know that there are instances where medication alone can make significant differences for patients. So As the pharmacist that I am, this is always my favorite part of this topic, talking about the different ways that we can help treat opioid use disorder. And like I said earlier, we're going to talk about the medication options that are available in the United States, as well as other behavioral and psychosocial supports that can be given. So first, what do the experts say? What should we be doing here? On our first slide, we talked about the American Society of Addiction Medicine, or ASAM. We also talked about NIDA, National Institutes on Drug Abuse. There's also the Substance Abuse Mental Health Services Administration, or SAMHSA, which makes up this trio of the main three leaders in this space who help guide clinical practice and develop treatment guidelines. Each of these organizations have their own recommendations for how opioid use disorder should be evaluated and treated. But the crux of all of them is that individualizing patient to have a whole patient-centered approach is key, along with using the medications that are approved for opioid use disorder in, again, combination with counseling and other social supports. I'm going to talk a little bit about the regulations that were involved with opioid use disorder prescribing historically. We'll talk about how things have changed over the years, but I think it's really important to note that this is talking about on a federal level. We heard earlier this morning about how there's still different regulations in the state of Ohio that other states might not be experiencing. So keep that in mind that this, again, is federal. But it started in 2000 with the Drug Addiction Treatment Act, where physicians were the only ones able to prescribe for opioid use disorder. And in order to do so, they had to complete requirements to fulfill what is called an X waiver. They also couldn't treat more than 30 patients at one time. So this is quite limiting. In 2002, buprenorphine was approved as an option of medication for opioid use disorder. Buprenorphine was different than what was currently available methadone, because to receive methadone, patients had to go to specialized clinics on a daily basis to receive those doses, whereas buprenorphine is able to be dispensed by a community pharmacy. So this was a big step in expanding access for patients. Then in 2016, the Comprehensive Addiction and Recovery Act actually expanded prescribing privileges to nurse practitioners and physician assistants. In 2018, the Support Act expanded those prescribing privileges further, but it also expanded the ability for these providers to treat up to 100 patients in their first year versus the original 30. In 2021, the Department of Health and Human Services exempted who were treating less than 30 patients from having to fill the Data Act requirements, so they did not need the X waiver. And interestingly, in December of 2022, this is most recently, the MAT Act actually removed the requirement for prescribers to fulfill the X waiver requirements in order to prescribe medications for opioid use disorder. Again, this is federally. I learned today that the states did not all have to follow suit. And while in Ohio an X waiver is not necessarily required, we learned about the 8 hours of CME that's required in order to do so. And I even learned about other practitioners having different requirements beyond the 8 hours. So definitely room for improvement there, I would say, as we called out earlier. But interestingly, across the country, despite the X waiver requirement being removed, we haven't actually seen major increases in medications for opioid use disorder prescribing. I'm hopeful that it's because we're in early on after this happened and there will be a big uptick, but who's to say? Something else I want to point out too is notice the time period of when changes to expand access really came into play. You'll notice from 2016 to 2020, there were 4 major access. This is on, right? Okay. To try to expand access. And you can see, like I said, that's only over 6 years. Prior to that, we went 16 years from 2000 to 2016 before any updates were made to the initial regulation. I want us to think back to that waves of the opioid epidemic slide that I showed, and really to call out what happened in 2013, or what did that mark? That was the initial wave involving the synthetic opioids. So you can see that regulations quickly after this third wave had begun were starting to get updated. And again, the goal is to have expanded access. Okay, so my favorite part, the medications. All of the medications for opioid use disorder work on the mu opioid receptors in the brain. These are the receptors that when opioids bind to them, allow for opioids to exert the effects that they do. So these are things that you might expect, like pain control. Other things like euphoria come from the same receptor. Also, the dangerous parts of opioids come from this receptor, like respiratory depression and the other side effects that we see with opioids. It's all due to the activation of these receptors in the brain. So while all of the medications work on these receptors, they do so in different ways. There are three main mechanisms that you can see demonstrated by this slide, and you can get a sneak peek into how we expect them to work based on these symbols in the middle of the screen. You see we have the drug chemicals bound to receptors on a brain, and then you can expect different physiologic responses, and you can get a clue into what those might be based on the number of lightning bolts or even the lack thereof. So a medication can be a full agonist, like methadone. This medication works by binding to opioid receptors, and we get full activation of those receptors. The opioid effects increase with increasing doses, as we see with the blue line with square data points on the graphic of the left side of the screen. The opposite of a full agonist is an antagonist, things like naltrexone, naloxone, and nalmefene. These molecules work by binding to the opioid receptors and blocking them from any activation. It's like turning them completely off. This is represented by the red line with triangle data points in this graphic. And in the middle, we have things like buprenorphine, which are partial agonists. So what we see with buprenorphine is that we do get increasing opioid effects with increasing doses, but only to a certain point. You'll notice that we reach this ceiling effect where the opioid effects are capped off. So all of those opioid effects that you expect with an opioid are impacted by this ceiling effect. I like to translate all of this science into more digestible language. So bear with me during this analogy here, but I like to think of this like a dimmer light switch that you might have in your house, in your office, where a full agonist is like you walking up to that light switch and turning it completely on. Your lights are on to the full extent that they can be. The room is full of light. The antagonists are like flicking the light switch off. It's dark. There's no activation of the receptors. And then the partial agonists are like that dimmer switch feature where we're turning the lights on to a certain extent. So it's not dark in the room, but it's not nearly as bright as it can be with the light switch turned on completely. We'll dive into each of these medications and what's available in the coming slides, but this table shows a quick overview of what FDA-approved active ingredients are available in the United States. You can see that we have the medication name along with the way that it works at the opioid receptors listed in these two columns. What we know we have is methadone. We also have buprenorphine in mono products as well as in combination with naloxone. And then we also have naltrexone as an antagonist. So diving into each of these in a little bit more detail. Methadone, again, that's our full agonist. As you can see by the graphic here, this results in full activation of those opioid receptors. Methadone does tend to have a slow onset, and it's available as oral, liquid, and tablet formulations for daily use. I mentioned this briefly earlier, but in order for patients to receive methadone, they have to go to specialized opioid treatment programs to receive that daily dose. There are instances where eligible patients may be able to take some doses home, but for the most part, it requires those daily visits to clinics to get their therapy. Then we have buprenorphine. Again, this is our partial agonist, where we're seeing those receptors getting activated to a partial extent. Buprenorphine's been on the market for a very long time, and it exists in many different formulations. Aside from being a partial agonist, which helps with things like craving and withdrawal, it has some pretty unique pharmacologic properties that help it to be beneficial in this disease state. So buprenorphine, whenever it binds to the opioid receptors, it has a very high affinity, which means it binds very tightly. It also has a very slow dissociation, meaning that it's very slow naturally to come off. So with that combination together, whenever we have high or adequate enough concentrations of buprenorphine, actually allow it to block other potentially more dangerous opioids from binding and exerting their more dangerous effects. So this is a unique characteristic of buprenorphine as well. Like I said, there are many different formulations. We have the mono product of just buprenorphine, as well as the combination with buprenorphine and naloxone. These are available as sublingual and buccal tablets, as well as films. Newer to the market and are the long-acting injectable formulations of buprenorphine. So now we actually have a once-weekly long-acting injectable that's available and 2 different once-monthly long-acting injectable buprenorphine products as well. And lastly, naltrexone. This again is that antagonist, the receptors being turned off. Naltrexone is also available in multiple formulations. It comes as a once daily tablet or as a once monthly long-acting injection as well. So even though the inner pharmacist in me loves medications, I'm going to hit on this point until I'm blue in the face that medications are only one part of this entire treatment process. We need to be viewing patients as whole patients and knowing that there are different components to leading patients to those positive outcomes in their journeys. Different areas that need to be addressed are behavioral therapies, the need for other medical or psychiatric services, as well as social services. So just like there's evidence-based medications that are available in this disease space, we also know that there are several different behavioral therapy modalities that can be helpful to patients. Things like motivational enhancement therapy, as well as cognitive behavioral therapy, like otherwise known as CBT, are very helpful. There are other evidence-based treatments also available, including things like individual drug counseling, social support counseling, contingency management, and also mindfulness meditation. So I kept talking about the importance of psychosocial supports, and it's really important to take a moment to really define what we mean by that. Another term that you're likely more familiar with is social determinants of health are these factors. And I know Centers for Health Affairs has the new innovation hub focusing on these social determinants. So it's important to call them out as they play a very key role in any chronic disease management, but especially opioid use disorder. These include services like recovery support, housing, access to having health insurance or financial support, as well as food assistance and educational and vocational opportunities. Let me give you an example about how methadone can actually, how these factors can impact somebody's potential success with something like methadone. So we talked about the need to go to the opioid treatment programs in order to receive those methadone doses. For some patients, that is extremely beneficial for them to have those daily touch points with the healthcare system. However, in a patient who has no transportation or lives in an area that they can't easily access those treatment programs, methadone may create more barriers for that patient that are in their already uphill battle. All of the medications have their different nuances of what can be impacted by these factors, but it's just of utmost importance to consider these when we're working on making treatment plans for our patients. Okay, so what's the key formula here? It's been established that to optimize treatment, the gold standard is the combination of medications for opioid use disorder with counseling and other psychosocial supports. I want to really emphasize that this is not an either or situation, it's a both and. So both medications and counseling can enhance the importance of healthy rewards. It can help mitigate stress reactivity and the negative emotional state that patients experience whenever using opioids. It can help patients learn how to plan ahead and avoid situations that they might be particularly vulnerable. And it can also help them understand the different environmental cues that they're exposed to that may trigger return to symptoms. So I know that was a lot of information. I want to hit on some important key takeaways that I hope you'll all take from this conversation today. First being that opioid use disorder is a chronic and treatable brain disease, and that stigma can have an extremely negative impact on individuals with this disorder. There are multiple different factors that play into somebody's progression to an opioid use disorder, and that medications in combination with behavioral therapies and other psychosocial supports can really help improve treatment outcomes for patients, including things like retaining them in treatment, reducing the risk of opioid overdose death, and even reducing illicit opioid use in general. So with that, I really want to thank the Center for Health Affairs for organizing such an incredible event. I know I'm really invigorated to continue on with my passions in helping patients with opioid use disorder by all of the work that you all were showcasing earlier. I also really want to thank Jody for having me this afternoon to speak with you all, and of course to the audience for all the work that you're doing out there to really help our communities, but also for your time and attention during this hour. So I think we have a little bit of time for Q&As. I'm happy to try to address any questions that I can. I think a microphone's coming.
A microphone for those in the room. And then for those of you online, please feel free to chat your questions and then we'll get to those. We'll be monitoring the screen for you all to get to those. Is there any questions from the audience here?
Hi, thank you, Dr. Laffey. My question is about screening, and if you can talk to any screening tools that you're using. I guess I'll kind of add that the loaded question is that I've personally experienced seeing individuals who have had a one-time opiate use, which was really supposed to be a suicide attempt, failed suicide attempt. But they were labeled as having opiate use disorder. And if someone were to understand their trauma, grief, and the reasons that led to their one occasion opiate use, they would not have been labeled OUD. So if you could speak to the screenings
Sure.
and how the diagnosis is made.
There are several different screenings that can be employed to try to identify patients that may have a substance use disorder or opioid use disorder more specifically. There are actually DSM-5 criteria that call out specific criteria for what constitutes an opioid use disorder diagnosis. The hardship that you explained about the, crossing of the screening tools and, maybe its lack of sensitivity to different situations, I think is unfortunately not unique, as we even saw today with Dr. Papp's data about the number of hits that the record identified versus those who actually fit the criteria for the SUN program. So that's not alone, and that's a hardship faced by everybody. Does that answer your question? Yeah.
I'm a researcher at CASE. My name is Ryan. Thanks for presenting. I've read a little bit recently about kind of different medications that could potentially be useful for this problem, but haven't been tested on humans or not approved. Do you know of anything up and coming that's specific to tackling fentanyl or some of this, the stronger opioids, as you alluded to?
Sure. So I'm not sure of anything right off the bat, but I think that is good to share with the whole group. But I'd love to connect with you after this and we can maybe have that conversation. I do agree that the pipeline for these drugs is very exciting, but due to this being an unbranded education, I think it would just be safest to just bring this to a private conversation later, if that's okay with you.
Any other questions in the room? Do I see a question on the screen, Theo?
Or downstairs.
No, no more downstairs.
Oh.
We're all together.
Woo.
Yay. Not yet. Okay. Going once? Going twice? Oh,
Personal opinion. So I work for a company that is 100% telehealth,
Okay.
and we are in like 25 states, and Ohio is our biggest state. We have the most active. We have over 500 active. We call them members in Ohio, but we just started last month doing opiate and prescribing buprenorphine. And it's our understanding that, and we heard it earlier, that in the state of Ohio, you can get the medication, but you don't have to go to treatment. The question is, like, what would be a good way to tackle that resistance? Like, well, you don't have to go to treatment. Okay, well, I'm not going to treatment, even though we know based on that assessment that they would definitely benefit from treatment.
Sure. I think the challenging thing with this disease state and treating patients is that time is very much of the essence. And when we have that opportunity to connect with them, we need to take full advantage of it. So I hear, your frustration, and especially being with telehealth, you're not in the room with the patient. One of the main things that comes to mind for me would be even just trying to already schedule that next follow-up appointment after they receive their medication, knowing that if somebody's in active withdrawal, it's likely very challenging to have a conversation with them about some of the other supports that can help in their journey. Thinking back to that neurobiology, if you're in flight response, it's hard. I mean, even when I get too hungry, it's hard to reason with me. So I can only imagine. So I think maybe creating those opportunities up front while you have your audience and while you have your clients and then planning for the future discussions could help bridge some of that continuity. Right. Yeah, the patient's part of it's definitely hard. I think to educating the staff, just, those constant reminders, hey, there's other things that go into this. I think it's important to handle what's important now for that patient, but knowing as the trusted resource that the patients are coming to, that entire catalog and repertoire of ways that we can help should be explored. Thank you.
So I kind of had a follow-up question to hers. So what kind of research is out there showing? So I also am a bit fearful of the going from MAT to MOUD. So what research has been shown people that are just doing only medication versus those who have been in conjunction with other things?
Sure. There certainly are studies out there that have shown that medication alone has resulted in these positive outcomes compared to placebo without counseling. Oh. Sure. So let me be clear that the recommendation is certainly not just to do medications, and that including them as part of the entire treatment plan is still the gold standard. It's just now the terminology is evolving that we use to describe that medication component, just to emphasize that because there have been studies that have shown that just medication can still help. So not having access to counseling supports or other behavioral therapies shouldn't exclude somebody from receiving medication that can be life-saving. Is that helpful? Okay.
So it looks like we have one more question here. And then I also have asked those on the line, if you can please use the chat function. Okay, I see one coming through.
Yeah, I see.
And then at the end, I've asked the folks online to share that, since they weren't sharing questions, to share their biggest takeaway from the presentation. And I will repeat those once we get this final question.
Thanks. Thank you for the presentation. Our organization really tries to stay on top of the stigmatizing language. And one of the words that I saw on there that, you know, is acceptable is misuse. And I've been recently hearing that misuse is actually a stigmatizing word now. I know that language continues to change. And I think, you know, it's, you know, how can everyone kind of stay on top of that? And if you can just talk a little bit about misuse.
Sure. So I think what this slide is really getting at, you'll notice that there is use and misuse listed. And you can see the call out. It's a little hard to see from over here, but use being for reference to illicit drugs, whereas misuse being referring to prescription medications playing into it. However, I completely hear you and agree that it probably doesn't matter what is the substance or where it came from, just looking at, you know, the ultimate patient as that whole person. So that's actually great feedback that I think I'll bring back to our communications team to maybe look into that a bit more.
Thank you.
Okay, we have one comment on. Come on, folks that are online. We need your engagement here. We want you to participate. So text in the chat. What are your key takeaways from today's presentation? So we have one that's been posted, the comparison between treatment for OUD and treatment for cardiovascular disease is an insightful perspective.
Thanks for sharing that. I remember the first time I saw that slide in my materials, I was like, oh my gosh, this is perfect. I think it helps drive the point home that it really is a chronic disease.
And they're very quiet online today.
That's okay. But
Any key takeaways from the audience? Shout them out. You can just shout them out. Oh, none? Okay, great. That was a
thank you. I will be available. Like I said, I'm a resource to all of you at any point. If you have further follow-up questions or, you know, something you're specifically wanting to ask, I'll have cards where you can reach me too. Thanks so much.